Hi, and welcome to this short presentation in which we're going to unpack information bias. So what are we going to cover? We're going to look at sort of some background concepts, unpack differential versus non-differential, and give you a checklist for identifying observational bias. All right, so let's start with what information bias is, and the first thing I'll note is that you may see it written with other terms. Terms you may see are measurement error, you may see misclassification, you may see observation bias. There are some subtle differences in the terminology, but really the important take home is that when we look at an observational study, we can have a distortion in our measure of frequency, so in our prevalence or our incidence, or in our measure of association, so the odds ratio or the relative risk. And this distortion could be due to an inaccuracy in the way we measured the study factor, the outcome, or the confounders. And just to be clear, we could also have measured all three slightly wrong, and that means that the results could be biased. Okay, so where does this bias come from? Well, we deviate from the true value because of a number of sources, and often you'll see it divided into these three, and that is instrument error, subject error, and observer error. Now, the best way to kind of get your head around this is imagine when you go and you get your blood pressure measured at a doctor's, and the goal is to understand what your blood pressure is normally. And what could happen is that the equipment that's used to measure your blood pressure could be out, and therefore it's measured with error. It could be that you suffer from white coat hypertension, and so you're anxious and your blood pressure is elevated because of that. Or there could be an observer error, so that your doctor, for example, may have some difficulty with their hearing and therefore may not record it appropriately. So there are these three sources, and they can come in with the instrument, and the example we gave you was the blood pressure measuring. But your instrument in any epidemiological study could also have been your diagnostic test. It could even be the questionnaire in which you collect exposure information. The subject is obviously the person or the animal that's having data collected, and then there's the error in what the researcher or researchers have done. And so often we make a big deal about wanting to differentiate between differential and non-differential bias, and we're going to start by introducing these terms and talking about them. And the first one I want to talk about is non-differential. Now, there's a little bit of a clue in the name as to what non-differential means, and it means not different. It doesn't mean that there's no error, it just means that the error is the same across all groups. All right, so for example, if we were testing heifers and heifers and cows, so first parity and older, for leptospirosis, well, some will test positive and some will test negative because of an error in the diagnostic test. So we have imperfect diagnostic tests, and that's where error can come from. That error is going to be the same across all groups. That is, the sensitivity and specificity of the test doesn't change from heifers to older animals. It could be, if we were measuring something like daily gain, that you put animals across a scale and the scale is out by half a kg. Now that's going to be the same for every group. So non-differential comes in when we have issues with how we've measured, and there is no difference though in those issues between our different groups. So in a cohort study between our two exposures, in a case control study between cases and controls. In contrast, you may have something known as differential. And again, the clue in the name is it's different. And I'm going to unpack what happens in a cohort study and then in a case control study. So in a cohort study, it refers to the fact that we could measure differently the outcome in exposed and unexposed. And that could be that, for example, a very experienced pathologist reviews the histology from the animals that you expect that are more likely to have disease based on their exposure pattern, whilst an intern does the others. And the example I'm giving you here comes from my PhD, where what I observed in a number of the racing stables was that once horses started galloping, which was really my risk factor of interest, then they would be examined by a veterinarian a few times a week. And that veterinarian was a very experienced racetrack veterinarian and likely to detect very subtle changes in movement when he did the trotting up, and therefore pick up the earlier signs of lameness. In contrast, if the horses had not yet been exposed to high speed exercise, in other words galloping, then there was no trotting up of those horses, and they were just inspected by the trainer, and they ran their legs, hands down their legs, looking for sort of pain or heat. So you've got two different ways of detecting disease depending on whether the animal had been exposed or not. So that's an issue, and it's different. Okay, so the sensitivity and the specificity with which we could detect an injury will differ depending on whether the animal had been exposed. Now, the way to avoid it is really measure the outcome in the same way in both groups. This doesn't mean that you have to have one person always doing it, but ideally, if you have more than one person, you won't assign all of the animals to be assessed of one type to be assessed. So you will randomly, if possible, allocate who assesses what. Okay. Now, in a case control study, differential misclassification occurs because exposure is measured differently between cases and controls. Now, this doesn't mean that as a researcher we go in and we ask different questions of cases and controls. It occurs because by the very fact that you are a case, you have probably got a different recall in that you've maybe spent more time thinking about your exposures, or you may be less likely to want to tell the truth. Okay, and because we're pretty much always asking people about previous exposures in a case control study, that's how we get the data, and they always know whether they're a case or a control because we recruit them once they've been identified as cases. We're pretty much always going to have a recall bias issue. And as I said, it's when cases and controls remember and report their exposure differently simply because they know their disease status. So can you imagine if you've just identified as a case for a disease and you engaged in somewhat questionable behavior, and I'm sort of thinking of your farm has just broken with the disease, you may be less likely to want to admit what you did. Now, it's really important. A lot of people use recall bias to refer to any issue in which someone's had problems remembering. So if, for example, I asked you about what have you eaten in the last month, you may have difficulty remembering. That's not recall bias. That's just difficulty remembering. Recall bias only happens in a case control study. Okay, so just to clarify, if we're doing a cohort study and we are asking people to remember what they ate in the last month, they may have trouble recalling that, but that is an issue of recall. It is not recall bias. Recall bias only exists in a case control study, and it refers to the fact that cases and controls will remember and report differently purely because they are a case. Okay, so why do we care about differentiating these? And the reason we care is that if that error is differential, so it differs between the cases and the controls, or the exposed and the unexposed, then we don't know what it's going to do to the results. It could lead to an over-underestimation, or it could lead to an underestimation. We could find something was statistically significant when it wasn't. So we have no way of knowing which direction the effects go in. In contrast, non-differential bias pretty much always biases towards the null, which makes us less likely to find an effect. So this is the crux of why we care. If the error is likely to have been non-differential, so basically we use the not so great test, and we found that there was an effect, because that bias is always going to bias towards the null, so what it's always going to do is make it harder to find statistical significance, then we can actually say, well, yes, the effect was probably underestimated, but the fact that they found it was significant, it would have been significant even if we had a perfect test. Okay, so that's why it's useful. If it's differential, we have no idea what direction it caused the problem. If it's non-differential, then we still find it to be statistically significant, if we could remove that measurement problem, what we would have is just a higher estimation. Okay, so how do we check for observation bias? Well, the first thing we want to look at is when measurement could be subjective, was there blinding? Okay, and this often we're talking about this in the context of a randomized controlled trial, but if you're sending samples, say, to a histo lab to be examined, you could just as easily blind the reader to knowing anything about those slides that they're reading. So let's go through the three types of blinding. There's single blinding, and as the name suggests, you just blind one person. Normally when we're talking single blinding, we are talking about blinding in a randomized controlled trial where we don't tell the person receiving the drug, or in the case of an animal, the owner, whether they got the drug or placebo. We then have something called double blinding, and that would be when the researcher doesn't know who got the treatment or control drug, the treatment or the placebo. And a final one is triple blinding, and this is really only possible in a randomized controlled trial, and it's when the participants don't know what they got, the researcher doesn't know what they got, and the person doing the analysis doesn't know which was the treatment and which was the control or placebo. And the reason we don't want the analysts to know is that we want them to analyze the data as they would, and not sort of go looking for different techniques or different ways if they didn't find their effect. So triple blinding is something that's probably come out more commonly in the massive big human health trials, and it probably is best practice if you can do it. So what we want to know is, have people been correctly assigned to their disease or exposure group? So how well was that measured? And then if there's error and you think there's going to be an error, you want to decide if it was differential or non-differential. Now, just to be clear, in a case control study, when we talk differential, it's that cases were measured differently to controls, and that's always, pretty much always going to be the case. In a cohort study, we're talking about was disease measured differently between them. So just to recap, observation bias is when we measure something incorrectly, whether it be the study factor, whether it be the confounder, or whether it be the outcome. We want to know if it's likely to be differential or non-differential, because that helps us work out, which direction the effect might have been in. And one of the ways that we can minimize observation bias, particularly with subjective measurements, is to blind perhaps the person reading the slides, certainly if it's a randomized controlled trial, blinding the person taking the medication to what they've been given. Okay, and at the end of the day, though, I think it's important to note that it's next to impossible to measure everything perfectly. So it's really a little bit like selection bias. There is still some kind of subjectivity to how we assess things. Okay, so I hope that helps you understand a little bit more about observation bias, and any questions or comments, please don't hesitate to ask.